as we all know that we are in Onco Critical Care Society, we are here to study topics which are more relevant for the oncology oncologists who are more relevant for the intensivists who are working in onco ICUs. So in continuation of that, we are today we are going to discuss cytokine release syndrome in oncology, which is very relevant but less discussed topic. So for this, I would like to introduce Dr. Rachit Mehta. He would be presenting the case, and he has done his DCH, and then he is IAP IDPCCM, and he's a fellow in pediatric transplant critical care in Apollo Specialty Hospital, Chennai. So to moderate, I'll be moderating the session along with Dr. Saurabh. And for this case, for this discussion, we have two experts on our this thing. One, let me introduce Dr. Sandeep Jain. He's a senior consultant, pediatric hemato-oncology and BMT unit in Rajiv Gandhi Cancer Institute, Delhi. He has more than 15 years of experience, and he's a teaching faculty for National Pediatric Hemato-Oncology Program, and he has more than 50 research publication in national and international journals. Welcome, Dr. Sandeep. And
Thank
now
you.
I would like to introduce Dr. Indira JayKumar. She's very dynamic lady. She has done his basic education, DCH, DNB, and then followed by fellowship in pediatric critical care from Australia. And she is working as a lead pediatric intensivist, senior consultant ER and PICU in Apollo Specialty Hospital, Chennai. And she is program director for first IAP pediatric transplant critical care course. And she is the chairman of ECMO Society of India Pediatric Wing. Welcome, Dr. Indira. So I would request Dr. Rachit to please start the case presentation.
Good evening, everyone. Thank you, Dr. Parveen, Dr. Saurabh, and whole Onco Critical Care Society for giving this opportunity. So we'll start with this taken by Strom in cytokine release syndrome in oncology patients. So mainly in this recent years, cytokine release syndrome has emerged as a critical concern in oncology field, particularly when in the context of novel immunotherapies and targeted therapies. So understanding the pathophysiology, clinical manifestation, and management strategies of CRS is essential for oncologists as well as intensivists. Uh, it's very useful. So today we'll delve into a comprehensive case-based discussion on CRS in oncology and exploring its challenges, evidence-based approaches, and within the oncocritical care. So as we uh, uh, as we develop the cytokine release syndrome, is a so let us embark on a journey through clinical scenarios where each case serves as a canvas of deeper insight, informed decision making. So, Dr. Indira, can you tell about in brief about the cytokine release syndrome?
Thank you, Onco Critical Care Society, Dr. Parveen Kaur, for this opportunity for this webinar. And we are going to be discussing cases that we have managed and which will actually give an idea to all those who are participating here, how cytokine release syndrome in oncology is managed, the guidelines and evidence base. So cytokine storm, that is just a broad term. It's a syndrome, and it can occur due to various diseases, which can be due to infections, autoimmune, oncology, transplant, and drugs. So basically, there is immune dysregulation, and there's lethal hyperinflammation with a lot of circulating cytokines. And this proves to be very bad because then you have systemic inflammatory response. And this cytokine storm wreaks havoc in the body, causing multi-organ dysfunction, which is disproportionate to the initial trigger. And when we say the term cytokine release syndrome, it is specific to oncology, the immune therapy, the stem cell transplant. And that is what we are going to discuss and show through our cases.
So it's rightly said, the cytokine release syndrome is a potentially life-threatening systemic inflammatory response observed due to multiple reasons. So immune activation is the mainstay of this therapy, and that has been associated with like plenty of inflammatory cytokines like IL-6, CRP, ferritin, and all. So, uh, Dr. Indira, can you tell about the clinical manifestation, what we are dealing with in CRS?
So CRS in oncology, so that it is like a tsunami inside the body, and non-specific symptoms can be there. So you have fever, you have like flu-like syndrome, etc. But what is very concerning is this heart involvement, myocardial dysfunction, and respiratory distress because of capillary leak, and then your DIC. Apart from that, you can have virtually every organ that can be affected, your liver, you can have acute renal failure, etc. So you can see from this thing, it is multi-system. And the key is to recognize early before it progresses on to different higher grades and, stop the storm.
Yeah. So correctly said, severity can vary from mild symptoms, including like our constitutional symptoms like fever, malaria, fatigue, to severe symptoms, but not limited to only ARDS. Apart from that, hypotension, DIC, any liver renal toxicities. So next, Dr. Sandeep, can you tell about what are the risk factors for CRS in oncology?
Yes, if we have to discuss about cytokine release syndrome in pediatric oncology practice, we see this CRS mainly in two settings. One, when we administer immunotherapy to the patient, and second is in the bone marrow transplant, especially haploidentical transplant. If we have to talk about the immunotherapy, it can be seen with any agent such as ATG, rituximab, alemtuzumab, brentuximab, or nivolumab. But immunotherapy which engages T cells are more likely to cause CRS. And these two main things are blinatumomab and CAR T cell therapy. Other than the agent, it is also very important to note that CRS is more likely when we administer these immunotherapy with high burden of disease, because more antigen is available and therefore more recruitment of cytotoxic T cells. So sometimes what we do, we give cytoreductive chemotherapy before giving these immunotherapy. That decreases the risk of cytokine release syndrome. Also, it is very important to note that the maximum risk of developing CRS is during the first cycle of immunotherapy, and the risk goes on decreasing in subsequent cycles. So maximum risk is during the first cycle. And if we have to talk about transplant, we know that haploidentical transplant is most likely to cause CRS compared to mud and matched sibling donor transplant, because we know soon after infusion of stem cells, there is proliferation of alloreactive T cells and they causes CRS. And this risk is more when we use peripheral blood as the graft compared to bone marrow. Also, if the graft has higher content of CD3 positive cells, it is more likely to cause CRS. Definitely high serum ferritin or endothelial activation prior to this may predispose to CRS, but the main two things are immunotherapeutic agent and the haploidentical transplant.
Like you said, sir. So, Dr. Sandeep, just can you enlighten us for any specific timeline is there in CRS post-transplant that we have to keep in mind while managing this patient?
Cytokine release syndrome can occur during conditioning, soon after stem cell infusion, and at the time of engraftment. So we shall be discussing all these scenarios in our subsequent cases. So during conditioning, we use ATG, which sometimes can cause CRS. We will discuss this. And then, as I told before, also soon after stem cell infusion, there is proliferation of alloreactive T cells, and this also can cause CRS, and which is abrogated soon when we give cyclophosphamide on day 3 and day 4. And then at the time of neutrophil recovery, at the time of engraftment, the patient may have CRS. So these are the 3 time points where we have to be having high index of suspicion of cytokine release syndrome and manage accordingly.
Dr. Indira, can you tell about it's a very complex pathomechanism, but just can you give about in brief about the mechanism of CRS, which at the end we are dealing with MODS.
Yes. So you can see, if you look at this infographics, there are different triggers, which we already discussed. So you have all your pathogen, that is infection-related triggers. EBV associated HLH, COVID-19, the nitrogenic, your CAR-T, all that Dr. Sandeep had mentioned, your Blincyto, T-cell engaging immunotherapy, etc., a primary, secondary HLH. So what happens is it stimulates your innate immunity, then you have your adaptive T cells, and there is a significant, outpouring of unbridled cytokine release, and there can be many. So each condition, disease can have different cytokines predominating, and you can see the different targets and the drugs that can be used for each of these cytokines. And there is no negative feedback. That's the problem. So it's just uncontrolled, and that, if progresses, can against propagate and cause multi-organ dysfunction syndrome.
Like along with this pathomechanism, Dr. Indira, just can you tell about the words, what in the mechanism only, and about endotheliopathies and pyroptosis?
Yeah, so this is very interesting, this word pyroptosis. So we have all heard of apoptosis, which is cell death. But when you have cell death, along with release of pro-inflammatory cytokines, perpetuating organ damage, that is called pyroptosis. And what happens here is we all know about DAMP, PAMP, that is pathogen-associated molecular pattern, damage associated. So there is a trigger. And whatever trigger that is recognized by some receptors called PRR, pathogen recognition receptors, and then this will stimulate your innate immunity, your macrophage, neutrophils, NK cells to release cytokines. That in turn will stimulate your adaptive immunity, your T cells. There's more outpouring of cytokines. And this actually continues like a loop with no negative feedback. And there is vascular leakage, endotheliopathy. And this is how multi-organ dysfunction sets in, regardless of the etiology of your cytokine release syndrome.
Rightly said. So, Dr. Sandeep, can you tell about what are the criteria we are following, and any particular hallmark of this triad is there for CRS?
Okay, when we are suspecting any child to be having cytokine release syndrome, we need to actually classify its grade. It is very important because the further treatment and intervention are based on this grading. Also, we have to know that this grading is dependent on the underlying condition for which we are treating the patient. Suppose this patient is undergoing bone marrow transplant or receiving immunotherapy, then we use this Woodley's criteria. And it classifies CRS into 4 grades, grade 1 to 4 with increasing severity. And it takes into account 3 features actually: fever, hypotension, and hypoxia. These are the 3 cardinal features based on which this grading is done. So in grade 1, the patient has fever and may have some constitutional symptoms like myalgia, rash, diarrhea, headache, dizziness. Important is that this fever should not be because of any other cause. There should not be any identifiable cause for this fever, and it should be without any focus. Then, along with fever, if the patient is developing hypotension, but it is responsive to IV fluid or low dose vasopressor, then it is grade 2. But if this shock is profound and patient is requiring higher dose or multiple vasopressor, or oxygen requirement is more than 40% FiO2, it is grade 3. And it is grade 4 if patient is requiring mechanical ventilation. And there's one more classification. When we are giving CAR-T, then we are using this classification. This is given by American Society of Transplant and Cellular Therapy. It is much simpler and more widely used, basically because it is dependent on the degree and the type of intervention you are doing, and it is not based on some specific measurements like 40% FiO2 or more than 40% FiO2. So grade 1 is same, fever with some constitutional symptom. Grade 2 is patient has hypotension, but it is just managed with the IV fluids and you don't need any vasopressor, or oxygen requirement is low, less than 6 liters per minute. If the patient is requiring vasopressor, this was actually grade 2 in the previous classification, but here it is just single vasopressor, it is grade 3. And or if patient is requiring high oxygen, like more than 6 liters per minute. If patient is requiring more than 1 vasopressor, then it is grade 4, or if patient is requiring mechanical ventilation, it is also grade 4. Basically, we have to remember these 3 things: fever, hypotension, and hypoxia, and with increasing severity, the grade increases.
Yeah, as I rightly said, only difference between these two grading is in old days criteria, vasopressors has been used as a grade 2, and this is much simpler version. And this grade 3 only vasopressors are required. Without in this grade revised AST/CT criteria, there are no organ toxicities I've mentioned, which is mentioned in old lease criteria. So that is the
Right.
only difference. Otherwise, all constitutional symptoms like fever, hypotension, hypoxia is same. I'm just sharing our cases which we already manage in our center. Uh, and coming to the first case, who was 8-year boy with B-cell ALL he was undergoing allogenic transplant. As a part of conditioning, child received ATG. So on the right side, you can see the vitals, which is showing a high heart rate of 168 with normal BP with significant hyperthermia. So Dr. Indira, can you tell about the possibilities or what is your impression at this point?
So here is a child who has just received ATG. So we all know ATG can cause reaction and it can cause CRS, cytokine release syndrome. And you have now the temperature high with tachycardia. So yes, I would think first of ATG-induced CRS, the grade 1. We've already discussed about the grading. Now, having said that, sepsis is something that you cannot completely rule out, because even though the patient has warm extremities and BP is high, many of our onco patients have hypertension to start with. So you still have to keep a close watch. But my first diagnosis impression would be ATG-induced CRS grade 1.
Rightly said. This is the case of ATG-induced grade 1 CRS. So we just manage with acetaminophen 15 mg per kg. Apart from that, no intervention was done. So Dr. Indira, can you tell about how do you manage grade 1 CRS and what monitoring is required, or any specific inflammatory markers you will do to see the progression of CRS?
So grade 1 CRS, all you need is recognition and close monitoring, antipyretics, as you all mentioned. Do we need any inflammatory markers to monitor CRS? No, we don't. Just look at clinical parameters. We all know CRP is a surrogate for your IL-6, which is elevated in cytokine release syndrome, but we don't go by CRP. You need it's more by clinical things that we institute our therapy, and we do not do ferritin. So no role for inflammatory markers. Just go clinical.
Yeah, right. So, Dr. Sandeep, can you tell when is the ATG used in hematonc or transplant patients, or any strategies by which we can reduce the risk of CRS?
So ATG is anti-thymocyte globulin, and in the hematology practice, the most common indication of ATG is when we use it for severe aplastic anemia along with cyclosporin. So here we use high dose of ATG, which is around 160 milligram per kg over 4 days. Then the second most common use of ATG is during bone marrow transplant. The basic purpose of using ATG in bone marrow transplant is twofold. One is to prevent rejection, and second is to reduce the risk of graft versus host disease. The type of ATG, whether equine or rabbit, and the timing of ATG is variable depending on kind of transplant that you are doing. And most of the time, ATG is used in patients with benign conditions such as severe aplastic anemia and severe aplastic anemia undergoing transplant, and in match unrelated donor transplant where risk of GVHD is high. Then whenever we have to plan ATG for any patient, we know that ATG is very notorious to cause hypersensitivity reaction. We, like in severe aplastic anemia, when we start ATG, we always start with methylprednisolone 2 milligram per kg for the first week, and then decrease it over next 3 weeks. It not only reduces the chance of hypersensitivity and CRS associated with ATG, but also reduces the incidence of serum sickness, which is a very fatal complication that may develop after ATG. Then, of course, all the patients receive H1 and H2 blockers, and round the clock paracetamol is given to all the patient. Another very important point that one should note, that when we start ATG for the first day, it has to be a prolonged infusion, maybe 10 to 12 hours, and in subsequent days we can reduce to 8 to 12 hours. Needless to say, all these patients are often sick. On the BMT unit, they have a central line in situ, and it has to be given through central.
So do we use
Right.
same dose in all the conditions, or the doses
No,
are different?
doses are different actually, depending on the condition and depending on the type of ATG we use. There are two different type of ATGs. One is equine based and other is rabbit based. And the rabbit is more potent. It is 10 times more potent than the equine, and the dose is 1/10 of the equine.
So are there
The
any less chances of having CRS with either of them, or what is the preferable thing to use? The equine one or the rabbit one? Is there any
So
difference
if
in
we are, yes, if we are using it for severe aplastic anemia, equine is preferred. But
the,
in the transplant setting, equine or rabbit are used depending upon different indication for which we are doing the transplant. That is variable.
and both are available freely?
Both are available in India, yes.
Okay. Sorry to interrupt बीच में. I thought I'll
No,
ask because then it becomes बाद में भूल जाती हूँ मैं.
No, true.
no.
No.
We have actually noticed hypertension and tachycardia, profound tachycardia, hypertension the minute ATG. So in fact, we had to start SNP infusion.
Okay.
Yeah. This
So,
is because
but the
ATG
classification
hypertension.
says that hypertension is one of the criteria. So if we are using SNP initially, so doesn't it increases the chances of patients going into, because I don't have any much of experience with these two drugs. So that is what was the idea. So
So
See,
initially,
ATG per se can cause hypertension, and we have to give high dose of methylprednisolone along with it. It also causes hypertension, and sometimes patient is on cyclosporin also, which also causes hypertension.
all right,
So that's why these patients are more predisposed for hypertension. But definitely, despite all this, the patient may have
still goes
severe
into hypertension.
hypertension. Yeah.
SNP is very short-lived, so that is an
Yeah,
advantage.
that is.
So we'll come to case scenario 2. We have a 6-year girl who underwent haplotransplant for severe aplastic anemia. After 48 hours, she started having fever. So vitals are showing tachycardia with high BP. Child was having some respiratory distress with hypoxemia on room air with hypothermia. So Dr. Indira, can you tell the possibilities here?
Yeah, so now we have a child who's undergone the haplo HSCT 48 hours later. So this is the time I would expect allo fever, the allo effect CRS, and we can see there is sudden fever, there is tachypnea, the stats have dropped, there's a little, and you have warm CFT, slightly prolonged, but the blood pressures are normal. So it is compensated shock with hypoxemia due to allo effect. This is because your T cells, as Dr. Sandeep mentioned, they proliferate maximum around this time, 3 to 5 days. And that is why we also give the post-transplant cyclophosphamide. The only alloreactive T cells increase. It's not the memory or the regulator T cells. And so this is grade 2 CRS. And yeah.
So rightly said, this is compensated shock with hypoxemia due to allo effect, CRS grade 2. So what intervention we did in this case is we started on oxygen by nasal pumps at 2 liters per minute. With that, oxygen saturation is 96. We gave fluid bolus of 10 ml per kg with frequent assessment of fluid responsiveness or tolerance. We gave methylpred 2 mg per kg, and N-acetyl cysteine was started at 10 mg per kg per hour to reduce the cardiotoxicity. Uh, as a part of like on screening, we did echo and monitor for sepsis also. It's required, and only don't go by the lab numbers. We have to keep in mind about the clinical thing also. So, and at this point of time, we have to think about screen for sepsis, like any blood cultures, we have to send any old lines and CTs if required.
So this is very important. And the intensive care unit, the team is involved even in the BMT. The child may not necessarily be shifted to the PICU, but will be closely monitored. And for the low saturations, we would be starting high flow nasal cannula.
Dr. Sandeep, can you tell about what is yellow fever and what are the strategies to reduce CRS due to yellow fever?
So this is a haploidentical transplant, and soon after transfusion of these stem cells, we know that there will be proliferation of alloreactive T cells. And these T cell recruitment will cause release of cytokines in the circulation. And this cytokine causes fever. But we have to, and this is called allo fever because of haploidentical transplant. But we have to remember at this time, the child may be neutropenic, child maybe is very predisposed for infection. So high index of suspicion for any infection is also have to be kept in mind. We, as you rightly said, blood culture, and if any possible source of infection, that site should be cultured. Important is to involve at this time your ID specialist, your critical care team, pediatric oncologist, all should have meeting in together so that they can decide about the further plan. And if we suspect that patient may be having some infection also and we start antibiotic, it is very important to monitor this patient. And after 2-3 days, when we give cyclophosphamide on day 3 and day 4, all these alloreactive T cells are actually killed, and there may be sudden abrogation of this CRS and patient may become fine. And at this time, if cultures are negative, we should try to taper down our antibiotic, because once we start this antibiotic, these patients are neutropenic, and we know this neutropenia is going to last for next 2 weeks. So keeping antibiotic on board may be hazardous. So here lies the importance of your experience, your involvement of multidisciplinary team to decide about the judicious use of antibiotic in addition to managing CRS. So,
Rightly said. Yes, of course.
So, how can we reduce the incidence of CRS? This is actually somewhat debatable. We can discuss about the risk factor which may predispose for CRS, which are like if we are using graft from the peripheral blood, that is more likely to cause CRS. So in certain transplant setting, we are using bone marrow as a graft, and the risk of CRS is slightly low. Then in certain benign condition and even in the malignant condition, we are doing TCR alpha beta transplant. So actually T cells are of 4 subtypes: alpha, beta, gamma, and delta. Alpha and beta subtypes of T cells actually predisposes for CRS and also for GVHD. So there is a system by which we can selectively remove alpha and beta T cells, and we can give mega doses of gamma and delta T cells. This decreases the incidence of CRS. But the primary use of using this TCR alpha beta is not to reduce the incidence of CRS, but the other mechanisms are there for its use. So generally for CRS, if we use bone marrow as a graft, the chances of CRS is less, and if we are using TCR alpha beta depleted transplant, the chances of CRS is less.
Rightly said. So allo fever will be there at like day plus 3 to day 5 due to this T cell proliferation, and we can manage with the post cyclophosphamide high doses, which is 50 mg per kg for 2 days.
Generally, if the fever is because of CRS, after second dose of cyclophosphamide, the fever goes away and child becomes clinically better.
Dr. Indira, can you tell about how do you use HFNC in grade 2 CRS or any other oxygen therapy you can use, or just plain oxygen by nasal prong is sufficient in grade 2?
So in grade 2, according to the ATST, you just need low flow oxygen. But in these criteria, you can be giving a little more oxygen. We have a very, very low threshold of using HFNC, that is your heated high flow nasal cannula. The advantage is it reduces your dead space. So there is CO2 washout. It gives a little bit of CPAP, and it is heated and humidified. So it's not like dry air, which you will give even with your low flow oxygen. Plus, it definitely helps work of breathing. And so sometimes we are just on little bit of, flows and not much of FiO2, but still the patient, gets very comfortable. The work of breathing is reduced. So this is what we use. We use HFNC in the wards. We use HFNC in the BMT. And of course, it's so comfortable, the child does not have to be shifted to the PIC.
Yeah, rightly said. This 3 kids are there. We use HFNC in ward only. So no need to shift every child just to monitor in the ICU, because there are high chances of infection because they are having severe neutropenia. so we can manage in ward with HFMC. So coming to case 3, we are having 5-year-old girl who is relapsed ALL, underwent transplant. Apart from that, total body the radiotherapy, conditioning, chemo she received, and post-transplant cyclophosphamide she received. She started having fever with perianal pain on day 6. Vitals are showing on the left side. Dr. Indira, are you concerned about something this kid?
So this child has got the stem cell transplant, and the background, there is a relapsed ALL, so would have received a lot of chemotherapy, has received radiotherapy, which means the heart has been, these are all cardiotoxic. Plus the post-transplant high dose cyclophosphamide, which is also cardiotoxic. So I'm concerned that there could be underlying myocardial dysfunction, subclinical cardiac dysfunction, and this is kind of manifest by this disproportionate low heart rate for the degree of shock. Normally, when you have shock like this, a 5-year-old, this is very low blood pressure. You would expect tachycardia, but look at that, the heart rate is low. So I would, screen immediately or even start some drug with inotropy. The other concern is sepsis, because there is fever with perianal area pain. Now, these children are neutropenic till they engraft, and so they won't have an abscess. So if there is perianal area pain, this is suggestive that there is infection. This could be the focus of infection. Central line old may not really be the source, but I would take blood cultures, start antibiotic, and aggressively treat the shock with fluids, and of course inotrope, because I suspect cardiac dysfunction as well.
Yeah,
The
rightly said.
key is to differentiate between CRS and sepsis. And so for every CRS, we cannot, dismiss sepsis. We have to keep that in mind. But the temporal association, if it has been after ATG or soon after or during the allo effect time. So the temporal association of CRS we should know. And that's when the differential diagnosis of CRS also comes in, not just sepsis.
So, are there any studies by which you can differentiate CRS from sepsis?
So there have
Dr.
been
Indira?
so this is a study for, but it's more, research, different biomarkers to differentiate sepsis, but we're not going to discuss, but we do not do all these interleukins and other biomarkers, interferon, etc. Now, procalcitonin, CRP and ferritin can be elevated in CRS, but procalcitonin is useful to differentiate a bacterial infection or sepsis from cytokine release, and the cutoff is about 0.5.
Yeah. So rightly said, this left side study is showing like they monitor interleukin 1, and which is not easily available in India. And apart from that, turnaround time will be very much high. So rather than going by lab, we should go by the clinical. And yeah, as rightly said by Dr. Indira, procalcitonin is emerging as a uh, uh, like in a marker for sepsis, but only one number is not sufficient, and so we have to keep on monitoring. We have to see the trend basically, and we have to go by clinical, not only based on the procalcitonin.
It's very good for de-escalating the antibiotic. Even if you empirically start, if the procalcitonin level comes low, then you can stop the antibiotics. So it's very useful for that.
Yeah. Right. So coming to case 4, we have 13-year girl with B-cell ALL who received blinatumomab as a part of conditioning. 4 hour post infusion, child started having an increased work of breathing with hypoxemia, which was around 85% on room air. Heart rate was significant tachycardia with hypotension was there with poor perfusion in form of cold extremities. CRT was prolonged, and even child is very anxious, and intermittently child was getting irritable with significant hypothermia. So, Dr. Indira, can you tell your impression?
So here, as the lungs are involved, there is hypotension, there is shock, there is high fever, and Blincyto. We all know that can cause very bad CRS. So this is grade 3 CRS, and this child would require, support with HFNC or little more, would require inotropes and shock management. And of course, the Blincyto also has to be stopped because now the child has developed CRS, and restart only when the child is a lot more stable. So this is grade 3 CRS based on the ATST classification grading.
Yeah, rightly said. It's hypotensive shock with hypoxemia due to blinatumomab-induced CRS grade 3. So what intervention we did? We started on HFNC 2 liters per kg per minute with FiO2 of 50%. On that, saturation become normal. We initiated bolus of 10 ml per kg and started on epinephrine and norepinephrine infusion. And we gave methylprednisolone along with tocilizumab over 1 hour, and neck infusion was started at 10 mg per kg per hour. So coming to the progression of the case, initially lactate was 2.5. So after giving fluid bolus, still child was having hypotensive. So ATRI was started at 0.2, and echo was showing severe myocardial dysfunction. EF was around 40%, and IVC was full. So at this time, steroid was given, HFNC was initiated, and noradrenaline was started along with adrenaline. So after that also perfusion was poor. Child was having tachycardia with the hypotension with cold extremities. So at this point, tocilizumab was given along with methylprednisolone over 1 hour, 4 mg per kg. Still, child was having poor perfusion in form of feeble pulses, cold extremities. BP was little okay, but echo was showing diastolic dysfunction. So we started on milrinone at 0.5 microgram per kg per minute as an inodilator. So after that, perfusion got better, and but only thing we couldn't wean the inotropes after 48 hours of using milrinone. So we switched milrinone to levosimendan, and gradually over the time child improved. We weaned her from HFNC in around 4 to 5 days. Gradually we weaned her from we used cyclical inotropes as a like alternative with milrinone and dopamine for a week, and then child came out. So this is the picture of her after stabilization. So, Dr. Indira, you want to add something?
Yeah, this child's, I have now healthy respect for cytokine release syndrome after this Blincyto incident. This was a 13-year-old talking, and then you can see her blood pressure just, dropping within 1-2 hours to 60 systolic. So we had started high flow because, she was looking anxious and slightly dyspneic, but I was scared to intubate her because any drugs I give or positive pressure, I know she would arrest. So we just kept purging. We were on Adri, we were on NORAD, we were on vasopressin. Her heart is barely contracting, and she's still awake and on high flow. And then we know it is CRS. So we just got the TOSI 1 hour, gave it over 1 hour, and you will not believe. So we were just happy that she's alive with that low blood pressure. And we were on industrial doses of inotropes. And 2 hours later, you can see slowly the blood pressure is improving. So I have healthy respect for CRS, and I feel tocilizumab is invaluable. So, and this was a child who, and it took a while for that heart. It was like myocardial stunning. Took a while for the heart to recover. So what Rachit said, we had to do rotating inotrope therapy. And every time we backed off the Milri or thing, there would be there would be tachycardia with a drop in blood pressure. So, and this levosimendan. So 2 days of dobutamine, 4 days of milrinone. They say Sunday ki Sunday levosimendan. And that really helped. After 3 weeks, her heart improved. And this was a girl who demanded pizza. So, a special pizza was given because she rightfully deserved it. So can be very, very dramatic CRS. But another interesting thing, this child, we didn't have to intubate. So a message, you don't necessarily have to rush to intubate these children, even though they were on such high inotropes. As long as their airway is maintained, it's not severe work of breathing. If the SATs are maintained, don't rush to intubate because that could actually cause more problems. All the drugs given for intubation, your positive pressure ventilation, especially if they're underfilled, or the drugs, fentanyl, midazolam, or even ketamine, all these have negative inotropy, so they can arrest during the act of intubation.
Yeah, right, said. So, Dr. Sandeep, can you tell about any strategies we can use to reduce blinatumomab-induced CRS, or do we have any checklist for this CR?
First of all, I would like to congratulate for such a good management of this case. And I would like to tell Dr. Parveen that as we discussed earlier also, children are resilient, never give up on them, and they will come out of whatever is thrown to them. So despite having 3 vasopressor just on the verge of intubation, they come out so well. Because had this patient be having sepsis, the things would have been different. It was just CRS, and they improved dramatically when we give tocilizumab to this patient. So it
I
is
think
just time. The
I
drug.
think yeah, I think timely intervention and diagnosis is very important because as an intensivist, we always rush for, sepsis, septic shock. That was the first thing that would come to our mind. But if we
Right.
know the case scenario, if you know the background, we know the drugs given, then it becomes really easy to find that what is happening. And timely
That is why
intervention,
that is why we need like ID specialist on board, a
yeah,
critical care specialist, and a treating oncologist. All should have a close meeting to decide about the course of treatment.
true.
Now, coming to this Blina, actually, many of you might not be knowing about this drug. This is a immunotherapy. Actually, this is given 24/7, round the clock for 28 days. And whenever we plan any child to be given this Blina, we know that this child is at a very high risk of getting CRS, and the risk of this CRS is higher if patient have high burden of disease at the time of administration of this Blina. So generally we give this Blina after some cytoreduction, and we pre-medicate the child with single dose of dexamethasone 5 milligram per meter square before starting Blina, and then we start with the lesser dose to begin with. It is 5 microgram per meter square per day, and then if the patient doesn't have significant CRS for a week's time, then we actually escalate the dose to 15 microgram per meter square. Then important thing is this drug has to be given through central line. We cannot interrupt the line. We should not flush the line at all, because even small amount of blina present in the line, if it is flushed and goes in the circulation in a little time, then this can cause severe CRS. So if we have to give any other drug along with blina, we have to put cannula in the other hand, and we have to give drug through that. The other thing is, we know that blina can cause neurotoxicity. This may not be related to CRS. It may precede, or even it may occur after a few days of CRS. So what we ask our patient is to write a page every day. The first and earliest sign of neurotoxicity is they are not able to write in the straight line. And that is when we should actually try to predict that the patient may be having neurotoxicity. A close monitoring, daily twice examination, look for subtle signs of neurotoxicity, and that's so that we can pick it up early. These are the message I would like to give.
Yeah. Any guidelines are there, sir, for grade 3 or grade 4 CRS? What intervention we
Like
have to do?
this patient had a grade 3 CRS. So if patient develop grade 4 and require mechanical ventilation, then we can't give this drug anymore. It has to be discontinued permanently. But if the patient had grade 3 CRS, in that case we should stop the blina, do all other supportive measure as you did, corticosteroid, tocilizumab, and inotropes. And when this CRS comes back to grade 1 or 2, we have to hold it at least for 3 days, and then start at a lower dose, maybe 5 microgram per meter square. And if the patient tolerates it well, then we can escalate the dose. But if patient has recurrence of CRS, then even with this grade 3, we should discontinue this drug permanently.
Yeah, as rightly said, we for any grade 4 we have to discontinue permanently, and we can still use in grade 3 once the symptoms are resolved. So, coming to the like mechanism of cardiovascular toxicity. So, immunotherapy can affect like all components of cardiovascular system, which includes myocardium, blood vessel, electrical systems, pericardium. So, activated T lymphocyte, whether it's a CD4 or CD8, following immune checkpoint inhibitors have been shown to infiltrate into cardiac myocytes and skeletal myocytes, leading to local inflammation and damage. So there is a one fancy term called Takotsubo cardiomyopathy, which we had one case for that. So Dr. Indira, can you tell about, on the lab side, you can see the monitor for the same kid, and on echo we found it's Takotsubo cardiomyopathy. Can you tell about that?
So yeah, it is a fancy term. So one of the causes of myocardial dysfunction and cytokine release syndrome is either sepsis cardiomyopathy or Takotsubo cardiomyopathy. So what is this? It's called this stress cardiomyopathy or broken heart syndrome. There's a sudden histamines. Here it is cytokines. And when the CRS starts, we know this child is having CRS because you'll never see such high heart rate with normal blood, give some warning. But when you suddenly have fever with CRS, there's, cytokines. And be dysfunction, they say apical, but any chamber, even right side chamber can also, right heart also can be involved. And it is like a myocardial stunning. And you have to support this with inotropes and inodilators, probably similar to what the blind child had, the cardiac dysfunction that child had.
Yeah, rightly said. Dr. Indira, any role of levosimendan or milrinone in this cases?
Yeah, so when the blood pressure is low, you'll have to start adrenaline for inotropy. NORAD is more of a pressor. It helps keep the perfusion pressure in the MAPS high, but it's more of a pressor. Adrenaline is like the Brahmastra of inotropy. But you can't use too much of, these catecholamines because they increase myocardial oxygen demand, they cause profound tachycardia. So we have, especially when there is myocardial dysfunction, you have to initiate inodilators very early. If the heart rate is low, then we add on dobutamine. If the heart rate is okay, that means there is tachycardia, because then dobutamine, we do not prefer dobutamine because it's chronotropy. We would prefer milrinone, provided the blood pressures are near normal. So we would keep the adre, NORAD, and add milrinone, which is an inodilator, doesn't cause tachycardia. But milrinone has a very short half-life. Once the child is a little more stable, levosimendan is something that we add on because it has a very long half-life. And this magic drug has more up its sleeve than just being cardioprotective. It has also been repurposed for oncology for its anti-cancer effects. It sensitizes cancer cells to radiation. But of course, in cytokine release syndrome, we use it for its cardiac effects, its inodilator, it helps diastolic dysfunction, it doesn't increase myocardial oxygen demand, and it is given for 24 to 48 hours infusion, but the half-life lasts for about 5 to 7 days. So we can even repeat it every, Sunday, till the heart improves. So we have used it in our CRS patients. And I think there's a study which Rachit will, share.
So rightly said, advantages of levosimendan over milrinone is it is having anti-cancer effect apart, and it is having like a long half-life. We can use through peripheral line, and there is not much trivial events we have noted. So this is our experience. So we have used so far in 62 patients. So first line we used in 5 patients who are having underlying myocardial dysfunction due to like radiation or conditioning chemo. Uh, and second line, we used in shock after using our vasopressors or inotrope. That is most number of patients. So mainly we in 30% cases are septic shock. Around 8% cases we use this levosimendan as uh, we used due to engraftment syndrome or blinatumomab. Around 3% were myocarditis, and others 10% were having drug or disease related cardiac dysfunction. So what we found is a significant improvement in ejection fraction, around 8% in 5 days. But on long-term follow-up, all kids are having normal function. And only advantages of levosimendan is in this study only 5 cases are having trivial events in form of arrhythmia, and 3 are having hypotension, which can be easily managed with the reduction in the dose. So we are starting the levosimendan from at 0.1 microgram per kg per minute, and we are titrating based on the effect. So as Dr. Indira told, we are using this for 20, we have used this for 24 to 48 hours, and this is our center experience.
This is a learning for us. I have never used this drug before. Dr. Parveen, have you used it in your ICU setting in any of the patients with cardiac dysfunction?
Yeah, not here in Onco ICU, but yes, in normal ICUs, we have used these drugs. And it's a
Okay.
useful drug. Not in this ICU, I have not used yet, but otherwise, I have used this drug.
Okay.
This has been like promoted because it does not increase oxygen demand by the heart. So, but now
Yes.
some studies, mainly those are done in France, and they initially they tried in sepsis, but later on they don't find, they are it is not popular. So yes, around I think in the year 2012, 13, I used to use this for some years. Now not anymore.
Okay, thank you.
Yeah. So, coming to case scenario 5, we have one 9-month boy with SCID post-transplant through peripheral stem cell. From which is, who is showing increase, like significant rising trend of WBC between day 12 to day 14. So during this time, child was having an increased work of breathing with hypoxemia for that with significant hypotensive shock in poor perfusion. Child was drowsy and child was having severe hypothermia. So Dr. Indira, can you tell about the impression?
So this child is is an extremist, and sepsis I will rule out because the counts have gone up. So if this was a child with bad sepsis, your child would never engraft. This is the period in peripheral stem cells fall in HSCT when you expect engraftment, and the counts are going up rapidly. So that this is engraftment syndrome, and you have ruled out sepsis because the counts are going up. But now the child is engrafted, but the cytokines could be life-threatening. So we have to aggressively, manage this patient with respiratory support, with your inotropes, and look at the blood pressures, so hypotensive. So this is grade 4 CRS, has to be very, very aggressively managed, and the child in the intensive care. And what we would do, we would have to intubate this patient, look at the lungs are very bad. We'd have to throw in all your broad spectrum vasoactives and inotropes, adrenaline, noradrenaline. It can't even be, sequential. It has to be all at once to get your perfusion pressures high. Otherwise, your kidneys will pack up, which they did. And for this child, we also do renal replacement in the form of CRRT or peritoneal dialysis. So this child underwent peritoneal dialysis, not for AKI, but just for the child was peeing a lot. Many of our onco patients have tubular defects. So they continue to have, polyuria, even though they are in shock. So the reason for dialysis in this patient was acidosis, because acidosis makes you refractory to your catecholamines. And the fluids were, given your epinephrine, norepinephrine, vasopressin. We even had to give methylene blue because there was so much vasoplegia. Most important is giving your anti-cytokine drugs, because this is cytokine release syndrome due to engraftment. So you had methylprednisolone thrown in, tocilizumab. We gave totally 3 doses. We give 2 in the first day and then the third one in the next day under antimicrobial cover. Though, of course, the fact that the counts have gone up rules out sepsis. Of course, GCSF was stopped because the counts have gone up exponentially. So when children engraft, we know they will have problems with CRS, especially when the counts go rapidly high. So if it's 100 and then 500 and then 1,500, then they know they'll have we know they'll have CRS. If it's a slow rise in counts, then it's not so much a problem.
Dr. Sandeep, you want to add anything?
Yes, I think it's a nightmare for transplant physician. You keep on counseling every patient that counts will come, now we will discharge you, counts will come, now we will discharge you. But now when the counts are coming and he's landing up in another complication. So sometimes you need to have a very good counseling of the parents at this time, because they were not expecting this. With recovery of count, they were expecting things to go in their favor and they were preparing for the discharge. So it's become sometimes very difficult to explain the family that now he has landed up in a complication which can be really difficult to manage, and the child is sick and needs to be transferred to ICU. So that is something which we should be worried about.
Yes, so rightly said, as told by Dr. Indira, the child require intubation for respiratory failure. Apart from that, all inotropes were required uh, in epinephrine, norepinephrine, vasopressin, and methylene blue because of severe vasoplegia. Methylpred along with tocilizumab was given with under antibiotic coverage. Peritoneal dialysis was done for severe acidosis, and GCSF was stopped. So, Dr. Sandeep, can you tell about what is engraftment syndrome and are there any clinical criteria we have to look for?
So like in the case you described, engraftment syndrome is a known infectious complication of the transplant seen at the time of recovery of neutrophils. So when we call someone is engrafted, when the absolute neutrophil count is more than 500 for 3 consecutive days. So at this time point, the patient may have constellation of some signs and symptoms, which we call engraftment syndrome. And to classify it objectively, this is the criteria. It is a Spitzer's criteria, and it has three major components. Non-infectious fever, so your cultures are sterile, CT chest is normal, there is no documented source of infection, patient has skin rash, and patient has hypoxia. And there are minor criteria like weight gain, hepatic or renal dysfunction, and transient encephalopathy. If patient has all three major clinical criteria, then it fits into engraftment syndrome. Or if the patient has two major criteria and one minor criteria, then also it is engraftment syndrome. Again, it is more or less a clinical diagnosis, and we know at this time point with recovery of counts, infection should settle in. But again, infection is again one thing that we have to keep in mind, which may still be there. And also because this patient is now requiring ICU support, mechanical ventilation, is profoundly immunosuppressed. Neutrophils might have come, but the patient is still immunosuppressed. He's on immunosuppressive therapy also. So all aseptic precaution has to be kept in, because they are very predisposed for secondary infection. Sometimes they don't die of engraftment syndrome, but they may die of the sepsis that we actually introduce itogenically. So we have to be very, very meticulous in the management of these kids.
So rightly said, we also lost this kid due to various reasons during this period only.
Right.
Dr. Sandeep, just can you tell about and your experience about tocilizumab, when it can be used and what are the side effects? Are there any biomarkers we
So,
can monitor?
right. In cytokine release syndrome, we know that the most important cytokine that plays a central role in symptoms that are because of CRS is IL-6. And IL-6 is in supraphysiological concentration in cytokine release syndrome. What it does, it binds with its receptor, which is present in the circulation and also in the membrane of the cells. And it causes signal transduction and cause the damage to the cell. Now we have this humanized monoclonal antibody against IL-6 receptor, which is called tocilizumab. It binds not only to the soluble receptor, but also receptor present on the membrane, and thus competitively inhibit binding of IL-6 to its receptor. As Dr. Indira also said previously, it's a magic drug. Once the patient has a severe CRS and just one dose of tocilizumab, and within few hours, all the symptoms related to CRS may go down and the child becomes totally different. So side effects are not much, especially when you are using it for a very short period of time. Many a time, only a single dose is sufficient enough. We give 8 mg per kg, maximum dose is 800 milligram. So side effects are transaminitis or some transient elevation in cholesterol, but more or less they are not worrisome. It is quite safe when we have to use it just for a single or two doses. We have used in 7-8 patients so far, but it has worked very well for us.
Yeah. So apart from tocilizumab, any role of corticosteroid in this
Right.
cases?
In the management of cytokine release syndrome, two most important drugs are corticosteroid and tocilizumab. Both can be used interchangeably depending upon the availability. Tocilizumab is slightly costly and corticosteroid is like widely available, so definitely. But there are certain indications where we have to use one preferably over the other. Like when the patient has CNS symptom, we know tocilizumab does not cross the blood-brain barrier, and in that case, corticosteroid is to be used. And then there is some literature about corticosteroid that it decreases the efficacy of blina and CAR-T. In those settings, first we use tocilizumab, and if the patient is not responding to tocilizumab, we then give corticosteroid. However, in setting of transplant, many a times we use corticosteroid first, and if the patient doesn't respond to corticosteroid, then we add tocilizumab. About the other drugs, I don't have any personal experience of using any other drug other than corticosteroid and tocilizumab, but literature mentions about IL-1 inhibitor, anakinra, and also about TNF-alpha inhibitor, which is etanercept. But I have not used personally in any of the patient for CRS.
Yeah.
Dr.
Dr. Indira, you want to add anything?
Allo effect, would you, because the steroids can actually prevent rejection, would you give it upfront or just wait and decide depending upon the grade?
Yeah, initially there was some concern that if we give steroid for grade 1 CRS, it may actually influence, because we want these T cells to proliferate for the first 3 days. If the patient is not having much of the symptom, let them proliferate, because we have to bang them after they have proliferated. But if we stop their proliferation by giving corticosteroid, it may actually reduce its effect that it has to give on GVHD prophylaxis. So those proliferating T cell will later on will cause GVHD. So I won't act unless the patient is quite symptomatic or it is like grade 3, grade 2 or grade 3, but not in grade 1 at all.
So, Dr. Indira, are all cytokine storms are same in whether we are dealing with environment or HLH or macrophage activation syndrome or COVID-19? So, can you just tell in brief about this?
So they are same in one aspect. They are very bad. They are nasty. So, and all of them have cytokines. So which cytokine is more elevated? That depends on the underlying. So you have interferon gamma more in primary HLH, and therefore you have a particular MAB to target this. That's a mouthful word. So I'm not even going to try pronouncing it. Then COVID, we know it's IL-6, so tocilizumab, and then CAR-T as well. So in oncology, it is more IL-6, and that is why tocilizumab is used in such a situation. Yeah, so the another interesting thing that I read is all these cytokines can be elevated, but IL-10, the IL-10 actually comes down. So new research is, research is concentrating on drugs that could actually increase IL-10 apart from drugs that inhibit these cytokines. So just to keep the balance of your the cytokine balance. So there is a lot more work that has to be done in this field. The last word has not been said. That's all I can say.
Yeah, rightly so. Dr. Sandeep, can you tell about the world of cellular therapy? What is CAR-T
I
cell
think
therapy?
this is one of the most exciting and promising innovation that we have witnessed in last 1 decade in the pediatric oncology. So sometimes I wonder, why does someone get a cancer? It is because of the failure of immune surveillance. Our T cell has to stop the first cancer cell that come in the circulation, but somehow they fail to do what they were supposed to do. So somebody gets a cancer. Now we train these T cells again to fight against those cancer cells. That is what is CAR T cell therapy. So what we do, we harvest the T cell from the patient by leukapheresis, and then we infect them with lentivirus to induce certain protein on their surface, which will act on the antigen of interest. And in this case, like in BALL, it is CD19, which is the most commonly used CAR-T therapy. And then these CAR-Ts actually undergo ex vivo proliferation. We test them for their safety and purity, and then we again introduce back in the patient. And then these CAR-T cells actually hunt the cancer cells by looking at CD19 positive cells, bind to them, and destroy them. So this is like we have harnessed the power of immune system to fight cancer. And first CAR-T therapy was introduced around in 2011. Now we have 12 years of its use, mainly in the European country and North America. In India, it's still in very early stages. And this therapy has provided a ray of hope to many refractory and relapsed acute lymphoblastic leukemia patients who were otherwise considered incurable. So it's definitely very exciting, and let's hope more and more centers in India will have access to CAR-T therapy in future.
Dr. Indira and Dr. Sandeep, do you have any experience about dealing with this disease?
So we had
We had
one patient who, as part of a trial, Narayana and our in Bangalore and our hospital, we had 2 adults and then 1 pediatric. So this child was a relapsed AML who underwent CAR-T. We were all, waiting for the worst CRS storm in this patient, which fortunately this child did not have, and she's on follow-up. So as you can see, CRS can occur anytime. It's not, no particular days can occur. And then after that, you have your ICANS, which is more neurotoxicity. And then CRS due to HLH. So this is your timeline of complications following a CAR T?
So we at our center don't have our indigenous CAR T, but we two patients have undergone CAR T. Both are adult patients, and they have got this product from TMH Mumbai.
One thing important,
Dr.
as Dr. Sandeep had already mentioned, tocilizumab has to be used upfront if it is CAR T, not steroids, that he already mentioned. Unless you have neurotoxicity, and then you use dexamethasone because your toci does not cross the blood-brain barrier.
Right.
So, Dr. Sandeep, can you tell about any long-term side effects we have to deal with long-term CRS?
Generally, the patient who develops cytokine release syndrome have complete recovery in terms of their cardiac or neurological status, but sometimes patient may have persistent cardiac dysfunction. But it is very difficult to rule out whether this cardiac dysfunction is because of CRS per se, or because this patient have received so many anthracyclines in the past, it is because of that. So that dilemma is always there. And there is also some evidence that the patient who develop CRS are at more risk of developing acute graft versus host disease. But there is no concrete evidence and robust evidence to support this. I think more studies are required to actually prove whether they are really more prone for GVHD. I would say. I am more worried about than cardiotoxicity and GVHD. I am more worried about efficacy of my blina and CAR-T if I have to use steroid to manage CRS associated with this. That would be my more worry rather than GVHD and cardiotoxicity.
So there is an upcoming thing is cardiac oncology, and there is a new term called cancer therapy related cardiac dysfunction, which is due to multiple reasons like cumulative doses of anthracyclines or radiation therapy and post transplant with cyclophosphamide and all. So due to that child is having like subclinical cardiac dysfunction. For this kids, only measuring sometimes ejection fraction is not enough. Uh, so we have to keep this in mind. Only normal ejection fraction is not normal cardiac function in this kids. Dr. Indira, you want to say something about this cancer therapy related cardiac dysfunction?
No, so routine echoes may miss subclinical cardiac dysfunction. You actually need, global longitudinal strain, which the cardiologist has to, look for. Of course, your biomarkers, your NT-proBNP and all could be elevated, even if your ejection fraction is normal. So that is something that we have to be aware. Arrhythmias. We've had one child who had, very bad fatal ventricular arrhythmia, who had come with low heart rate, shock with low heart rate. So I'm very wary of a child who presents with hypotension and a disproportionately low heart rate. That child is going to decompensate much faster, will have much more myocardial dysfunction than the same child, another child with the same low blood pressures but tachycardia, because there the compensation is there by the heart. And we have realized that the heart can be affected due to multiple reasons in our onco patients. CRS is just one, another hit. So you can have multiple transfused thalassemics with iron overload of the heart. They are malnourished with thiamine deficiency, macro and micronutrients. They could have sepsis, which is another hit. And then, of course, all your cardiotoxic medications. So everything combined, the cardiac dysfunction could be multifactorial in our patients. And CRS is yet another hit. And therefore, they need a lot of, cardiac support. So drugs which have, inotropy. So that's a message that I would, want to give.
And I would just like to mention, recently we have done a study in 500 odd survivors of childhood cancer, and we have done GLS in those patients, and you will be surprised to know that 40% of patients have abnormal GLS, and ejection fraction was low just in 4 to 5% of the patient, but 40% patient had GLS abnormality.
So you have to publish. We were so keen to do this because this is such a very important message. Yeah.
Only thing
So
we are not having like compatible bedside echo machine to measure GLS. That's why we are not able to.
But
we are
even
doing
in the
it.
we can do.
We are doing it for survivors in outpatient clinic. We are not doing it for patients who are undergoing active treatment. That was just a late effect study.
That's a very important study. So imagine if the outpatient people have a low GLS, when they come very sick, their cardiac dysfunction could be much more.
Definitely. Totally agree.
Yeah, so coming to the last slide. So take home messages will be, first thing is recognition is crucial. So early recognition of any CRS is a paramount in oncocritical care. So vigilance for diverse presentation across different cases is essential. So second thing is a tailored approach to cases, whether it's due to any reason, whether it's a CAR T therapy, plinatumomab, engraftment syndrome. So tailoring intervention based on the specific characteristic of the patient is crucial. So multidisciplinary collaboration with PICU team, hematome team, and ID team is required. So successful management of pediatric CRS requires close collaboration between all these multi-speciality. Monitoring and escalation is equally important. And apart from that, ongoing research and advancement is shaping. So ongoing research is shaping new strategies for managing this pediatric CRS, and advances in treatment modalities and continued research efforts hold promise for the improvement in the outcomes. So I would like to thank all our PICU team, our hematome team, nurses, families, and most important, our kids who teaches us daily something.
Thank you, Dr. Rachit,
Thank you
Dr.
for
Sandeep,
sharing
and
your
Indira.
interesting cases.
It's a really interesting, and I myself I learned a lot.
Yeah.
If any audience have any query, they can type in the chat box. Till the
There
time
was
they
a
type, I have some queries, few queries I want to ask, clarify
Dr.
from you.
Saurabh, Dr.
Anyone?
Saurabh, Dr.
Yes.
Saurabh, there was a question in the chat. Somebody has asked that why
Let
lac
me
is used.
let me. I will take my opportunity to ask my query first. Then I'll take the other questions.
Okay, fine.
So my first query is like whether we can use extracorporeal therapy in cytokine release syndrome, for example, cytosol. Have you used it, or do you have any experience like using it? Or can you use it?
No, actually, we have not used. Extracorporeal, when you mean CRRT, we have used when they have gone and when they have
Like
performed
cytosol and all, like
But
immune optimum
cytosol,
therapy?
we have used it for septic shock, but we have not
Yeah.
used it in the context of CRS. But what we have realized is tocilizumab and CRRT, that kind of, helps. Yeah, we have not used. I don't know about Dr. Sandeep and
No,
your
we have
unit.
also not used.
We have
But there
not
is a
used.
possibility. Though I think there are some case reports where they use it. Yeah. And my second query is like that immune-related neurotoxicity due to the CAR T therapy. Can you use IL-1 antagonist in place of IL-6 antagonist? Because IL-6, as you said, it doesn't cross blood-brain barrier. Have you used, or is it available in India?
IL-1 is anakinra, which is available. In fact, it is cheaper than tocilizumab. So it's given twice a day, 2 mg per kilo. We have used in the context of cytokine storms with macrophage activation syndrome. That
Yes.
it is very life-saving, early anakinra, apart from your steroid cyclosporin. We have used it in that context. But, all the guidelines that for cytokine release in oncology is all about tocilizumab, not about anakinra. So,
But
yeah.
I think in CAR T therapy related CRS, I think it is not advisable to use TOSI, as you rightly said. Or
no, the guidelines that when we did our CAR T, the protocol that was given by the the people who are doing the trial was tocilizumab early if they develop CRS. Only if they have neurotoxicity to give dexamethasone. So it is tocilizumab. Yeah.
And I think
Because
in
the
India already,
cytokine-
like we have approved, next CAR is approved for India, right? That Mumbai IIT and I think TMC, they have collaborated. Have you started using it?
So no, this was part of a trial because it's very expensive. So it was free for the patient, but it is very expensive, very, very expensive. And after that, the patient has to be on monthly immune globulins, IVIG, because there is hypogammaglobulinemia. So that also could make you at risk for infection. So it is not, totally safe or, totally curative. We do not know. I do not have much experience except that one patient.
Thank you so much.
Yes,
Now,
CAR-T therapy is basically used in TMH and Narayana Hrudayalaya at Bangalore. But I think in a few more years, it will be widely available to many other centers also. Because for this, you had to run a trial to show its efficacy and safety in Indian setting. And this trial has been done both in TMH and NH. And probably now it will be available to many more patients. We
and
have
it
done
has been approved by DC I think in the last year October.
Yes, TMH
And they
Mumbai
claim
one
it is
is
cheaper
approved
than that.
and
That available in the Singapore.
yeah, it's much cheaper. It is like for any other therapy, it is costly in the developed country. It costs around 5 CR, USA, Europe, or Singapore. In India, they are offering it around 50 lakhs so right now, roughly. But proposed cost is around 50 lakh rupees.
Thank you.
Okay.
Thank you so much. Now we can take the question.
So there's
The
a
chat box.
question in the chat box: how to differentiate autoimmune toxicity and cytokine associated toxicity?
As Dr. Indira also has previously mentioned, it is about the temporal association. You are giving some drug and within few hours of a day, you get some symptoms, then you have to assume it is because of that immunotherapy. So generally the CRS after immunotherapy is within days. So we have to suspect that it is because of the drug, it is not because of any autoimmune condition at that time.
Okay. So there was another question in the chat box, and that was, what is the rationale for N-acetylcysteine?
So NAC is, there are many studies which have NAC is scavenging effect, cardioprotective. So if you're already this patient, this child, I think we had a case for 9-year-old plastic, so already transfused, heart could be, hit. And if you already have CRS grade 2 and you're now allo effect, you will be giving your high dose cyclophosphamide, which is cardio. So to protect that CRS hit, which could cause myocardial dysfunction, you're going to give a cardiotoxic drug. It's just so to support the heart that was given. It's more cardioprotective, and we use it always when we give the high dose cyclophosphamide. There are a few studies on the use of NAC.
All right. So
It's more supportive.
Yeah,
care.
Is there any question? I don't see any other question in the chat box. So if there are no questions, I think we can thank you so much, Dr. Sandeep. Thank you so much, Dr. Indira. And it was very nicely presented, Dr. Rachit. Dr. Saurabh, anything you have to add?
No, thank you. Thank you so much for
Thank you, Rachit,
It was
for your interesting cases.
Yeah, and it was very informative for us also. I read a lot of things today.
Yeah, I have learned a
So
lot.
thanks to three of you.
I think we are all learning every day from our patients,
Yeah.
from whatever we have to every some new learning, because no
Definitely.
patient behaves the same.
Same, yeah.
There's something
And the
always
way of learning is to present and to discuss. That is the best way of
Yeah,
learning. And
definitely. Thank you so
Yes.
much. Thank you, everyone.
Thank you.
Yeah.
Good night.
good night.
Thank you, Onco Critical Care Society.
Welcome.